everybody. I am thrilled to be back here again in Israel and be with friends, enjoy the best food of the world. Every time I hear Mark's talk, I'm inspired again, and every time I see a picture of Segev's workshop, I'm inspired again also. I think that might be a subject for a lecture in itself.
Same as us. Don't go to like...
This morning I'm going to share with you some techniques for osteotomies using intramedullary fixation, and greetings from the hospital that I now work at full-time in Port-au-Prince, Haiti. I've had to learn French recently, and if I come back and visit Israel too many more times, you're going to be expecting me to speak Hebrew. We're going to talk about a few deformities, analyze them, indicate intramedullary fixation, which, using the fixator-assisted nailing techniques, combines the accuracy of external fixation, providing rigid fixation that allows early rehab and weight bearing for our patients and avoids many of the discomforts and inconveniences of external fixation in the recovery period. When I look at deformities of the lower extremity, I think about just 3 steps. I have difficulty remembering classifications that are longer than 3. First of all, we look at what is the deformity, or is there a deformity, by measuring the mechanical axis deviation. And then step 2, we think about which bone the deformity exists in by measuring our lateral distal femoral angle, and keeping in mind, especially for the subject of intramedullary fixation, the 81 degrees, which is the anatomic lateral distal femoral angle, and measuring the tibia angles as well. And then the third step is defining where the apex is in the abnormal bone using the Cora or apex method. So we'll start by looking at a standard case of deformity using fixator-assisted nailing. This article was published by Herzenberg and Pele back in 1997 and really brought a great technique to light. What's that?
The third one was Rambam.
Oh, excuse me, Noam. Wow. I should have, yes. He's probably the one that did all the work and they took the credit, so I apologize for making that mistake. Using the 3 steps to analyze this deformity, we see a MAD of 33 valgus. Many times the MAD is documented as medial or lateral, and I always forget if the line is medial to the knee or the knee is lateral to the line. So in my documentation, I just say 33 millimeters of valgus, and on the left we have 0 millimeters of valgus or varus. And our lateral distal femoral angle is abnormal on the right side with 77, indicating a valgus deformity in the femur, and the tibia is normal. And then we also notice here that we have a leg length discrepancy, and the right side is a little bit short. So this is a case that's not ideal to do a closing wedge osteotomy. We want to preserve, possibly even gain as much length as possible. And when we analyze these cases for using intramedullary fixation, it's good to take into account the anatomic axis, because this is an anatomic axis type of correction. The normal anatomic axis varies by 7 degrees from the mechanical axis in the femur, and this can sometimes be a little bit more or a little bit less in any individual patient, and comparing to their opposite normal side can be helpful in making your preoperative planning. Just to point out here that the normal anatomic LDFA, again, is 81 degrees. And in thinking about the normal anatomic alignment of this anatomic axis between the femur and the tibia, there is a 6-degree valgus between those two in order to create a straight mechanical axis. So in cases where you don't have full-length x-rays, and also where you're doing analysis for intramedullary fixation, this anatomic method of analyzing can be helpful. One mistake that's commonly made is to draw the anatomic axis right down through the middle of the knee. The normal anatomic axis doesn't exit the center of the knee. It exits around 1 centimeter medial to the center of the knee. And in this case, the number 83 is being used instead of the 81 because it matches the opposite side and will create a, and also you have to determine what the tibia MPTA is in order to decide how much you want to correct your femur. This is a fixator-assisted nailing technique using blocking screws to prevent that knee from going back into valgus. I'm going to mention this again, but the blocking screw always goes in the concavity of the original deformity. And this is the sign nail. I'm not sure if anybody's familiar with this system, but it's used a lot in the developing world, and it doesn't take any fluoro to use this intramedullary nail technique. The distal interlock screws are put in at an angle to also prevent that deformity from going back into valgus. And the osteotomy is just a percutaneous osteotomy without any specific carpentry. Having an intraoperative sterile goniometer can also be very helpful in these cases. And here we corrected the anatomic axis to 83 degrees, and that matches nicely with the proximal tibial angulation in order to create a straight mechanical axis. And then the bone fills in, if we've seen this morning in a number of pictures from Mark's talk. Here's another case with a 33-year-old that had metaphyseal chondrodysplasia. This is Schmid metaphyseal chondrodysplasia, known as having short stature, and genu varum, and normal epiphysis. This little girl, and the whole family has this. The little girl has it as well. We were able to correct her with 8 plates, but the aunt here shows a multi-apical deformity with a mechanical axis deviation of 56 and 55 of varus, and measuring each of the angles shows relatively normal MPTAs with lateral distal femoral angle varus. Also important to look at the ankle and the hips. We have some varus in each of those, but it wasn't enough to need major correction. And this multi-apical deformity can also be corrected with fixator-assisted nailing. This is an inclinometer, which is helpful for fine-tuning your rotation, which can also be done using this technique. Placing a temporary external fixator and then a antegrade nailing technique was performed in this case. This was one of my earlier cases, and it's actually easier and more accurate to do retrograde nailings. Oftentimes we can't do it in the pediatric population because of an open distal femoral growth plate. And pre and post-operative image, she's still in a little bit of varus there, major improvement from before. And again, note the blocking screws placed on the concave side of the original deformity here. Another technique known as the lengthening and then nailing technique. This is especially helpful for correcting proximal tibia deformities, and the placement of the nail after doing the lengthening with the external fixator provides a stimulus for regenerate bone, and there's rapid consolidation that occurs after these cases, allowing early rehab. This is a case that was done with a talar spatial frame in a girl that had a 5-centimeter leg length discrepancy post-traumatic with a varus deformity in the proximal tibia. So you can provide a very accurate correction. It's important to place the pins outside of the trajectory of the medullary canal when you're placing the fixator, and then provide the lengthening as normally would be performed with the talar spatial frame. And once the bone is out to length, the frame is left in place, sterilized, and intramedullary fixation provided, at which time the frame can be removed and the patient free to start early rehabilitation. So just a few technique tips and tricks for fixator-assisted nailing. In this case, we have a valgus deformity, and it's important when you're doing a retrograde nailing for a valgus deformity to use a little bit of a lateral starting point with your intramedullary nail. As you can see here, if you started more medially, that's going to put the trajectory of the guide wire straight up the canal, and you're not going to be able to provide as much correction with this osteotomy. So start the point a little bit lateral when you're correcting a valgus deformity and a little bit medial when you're correcting a varus deformity. And then place the starting reamer, and immediately after you get your starting reamer in place, you can place the first external fixator pin, and I leave that reamer in place in order to assure that my fixator pin is going to be out of the trajectory of the nail. And then a second external fixator pin is placed. In this case, I use them out of plane. This is helpful for providing rotational stability, but these two pins could be placed in both on the lateral side if needed. It's important to look at the jig of your intramedullary nail device to make sure that your pins aren't going to interfere with the locking options on that jig. And so two pins are placed distally, and then one pin is placed proximally. This little diagram just helps understand that the distal fragment has lots of degrees of freedom of motion. It's only necessary to place one pin proximally, and I usually place that clear up in the metaphyseal area outside of the area where my nail will be going in order to have plenty of space and not have any interference from that nail. Then as soon as the fixation points are placed, the three pins, you can perform your percutaneous osteotomy. This should be done before your reaming because you want to ream after your deformity is corrected and also provide some vent holes in order to decrease the incidence of fat embolism. It's done usually as close to the apex of the deformity as possible, but you have to look at your implant locking options to make sure that you're proximal enough to the interlock screws to provide good stability in the distal femur. Most intramedullary nails have about 2 inches or 5 centimeters of space that they need to provide good, stable distal interlocking. And then once you've performed your osteotomy, you need to make sure you displace it in the correct direction if needed, and then you can place your fixator, lock it down, taking into account both the rotational and the angular deformity, and you can use your electrocautery cord to provide collinearity between the hip, the knee, and the ankle under fluoroscopic guidance. Without being able to place this external fixator on, the knee always has to be a little bit bent when you have your guide wire and your nail in place, and you're not able to assess it with the same level of accuracy as when you have the fixator on there to lock it down. This article shows the technique of using fluoroscopy with the electrocautery cord and confirm the accuracy of that technique. And next is the step of placing the blocking screw on the concavity of the deformity here. This blocking screw here is holding that fragment of bone rotated into a more varus position and not allowing it to go back into the original place that it was. Then locking the interlocks. This is also, you have the option to place your interlock screws from medial to lateral, which is not standard for retrograde nailing, but that's a key thing to remember that you can do if your jig is interfering with your external fixation pins. And always check the lateral view, make sure that your blocking screws aren't too long. You can see the lucency of where that external fixator pin is right here, anterior to the nail. And here is a pre- and post-operative image of this case. This patient had lateral knee pain with degenerative changes in the lateral compartment and chondromalacia. I did an arthroscopy first to assess exactly the status of the medial compartment and the lateral compartment and to decide exactly where we wanted that mechanical axis to fall post-operatively, which in this case was a little bit more medial than you might normally choose. Here's another case with a mechanical axis deviation on the right side varus and left side valgus, windswept deformity. We look at these numbers and note that we have an abnormality in both of the distal femurs and also in the right side on the tibia. The hip and ankle joint orientation were normal. And this case I did retrograde nailing in a staged procedure on the both femurs and corrected the proximal tibial deformity with a Taylor spatial frame. This is really helpful to provide a hexapod type of frame on a tibial deformity after doing a intramedullary correction with fixator assisted nailing, because then you can fine tune your correction by adjusting your spatial frame to the exact point that you want and getting your mechanical axis deviation right down through the middle of the knee. This case is a 15-year-old girl with a left patella instability, and you need to make sure that not only angular correction is provided here, but also rotational correction, and that can be done with intramedullary fixation. In this particular patient, there was an open procedure needed to provide patellar stability and rotation, and the angulation was relatively minimal, so I chose to do a plate fixation instead of intramedullary fixation. You want to make sure that if you have rotational deformity in the distal femur that you do not do a distal femoral internal rotation osteotomy, as that can adversely affect your patellofemoral mechanics. So that's one thing that you don't want to do, is internally rotate your distal femur. You need to do a proximal femoral osteotomy in those cases. So plate fixation indications can be good if the bone is too small for an intramedullary rod, when your distal femoral growth plate is open, and you can use it when not very much translation is needed. But when you need a lot of translation, there's clearly a benefit for intramedullary fixation. Also, with the plate fixation, the bone oftentimes doesn't heal as quickly when doing open osteotomies versus percutaneous. Combined deformity and correction with combining deformity correction and lengthening is something that we can now do with using the precise nail, and we published an article in the Yellow Journal on this technique with using a retrograde precise nail and correcting both length and deformity at the same time. This is a 14-year-old girl that sustained a right distal femoral fracture approximately 3 years before and developed a varus deformity and shortening of the right lower extremity over the next 3 years. She had a varus mechanical axis deviation. MPTAs were normal. LDFAs were increased on the right side. And then here's the length measurement showing 24 millimeters of shortening on the right femur. Options for treatment in a case like this could be done with external fixation. We could do a distal femoral osteotomy with a plate and shorten the opposite leg, or do the same thing with a delayed lengthening of that side, or do a retrograde precise intramedullary nailing. You want to make sure your canal is big enough to provide intramedullary fixation, and with the precise nail, it's a straight nail, so you need to ream 2 millimeters above the diameter of the nail. If you're using a 10.7 millimeter nail, you need to ream at least at 12.5, and you want to have at least another 6.5 millimeters of bone from your overall diameter. So in these cases, you want to measure the cortical diameter in your mid-diaphysis and make sure that you would have at least 19 millimeters of diaphyseal width. It doesn't matter what the medullary canal is, because you have reamers, and you can make the medullary canal whatever size you want. In this case, we use the same standard technique for fixator-assisted nailing. This one's correcting a varus deformity, so a starting point a little bit medial to the center of the knee, providing a provisional fixator, and then placing the precise nail. And here we see some initial distraction at 2 weeks post-op, and at 3 months post-op, nice regenerate grown in place. 12 months post-op here, and final result after removing that intramedullary nail. It's actually not necessary that you have to remove all of the magnetic nails. We published a report on the function of the precise nail after having MRI. There is no adverse consequences to doing an MRI in patients that have precise nail. No heating, no unintentional distraction or projectiles that are creating danger in the MRI scanner, but it does, the 3 Tesla MRIs will deactivate the precise nail, so it can't be reused. It takes away the magnetic mechanism. Yeah, okay. Final case of using intramedullary nailing for a multi-apical deformity in a case of fibrous dysplasia here, with both a proximal deformity and a distal deformity in the femur. 2 apices, and chose to cut the bone in 2 different locations, placing intramedullary nail, rotating around that apex, creating translation at the osteotomy site, and final alignment with final healing here. There was a small revision necessary. You see a broken screw up there, and fibrous dysplasia takes a little bit longer to heal in some cases than normal bone. Key technical points: thorough preoperative planning with long films. Confirm your implant and your bone size, leaving enough room for reaming, and at least 3 to 3.5 millimeters of cortical diameter surrounding the nail on all sides. Blocking screws go into the concavity of the original deformity. Know the interlock options of your implant and what level you need to make your osteotomy, and then avoid internal rotation for distal femoral osteotomies.